Hello again. This is Faisal Latif from University of Oklahoma. I will be talking about a case of the acute MI gone wrong, lessons learned from a team-based error. And I thank the Gulf Intervention Society for giving me this opportunity to talk at the Quality Summit. Here are my disclosures. So let's start with the case. A 74-year-old man presents with chest pain. Now, baseline is that he was doing fine until recently. About 6 weeks ago, he started having exertional chest pain. 4 days prior to his presentation to the ER this time, he had an exercise stress echo, which showed inducible ischemia, and therefore the plan was to do a heart catheterization. And then he had an episode of chest pain at rest, and he was a good patient. He presented to the ER after that. And no significant past medical or surgical history. His physical exam was fairly unremarkable. Blood pressure was slightly high at 145/81. Pulse was 84, afebrile. And as I mentioned, his physical examination was pretty normal. The EKG showed, some non-specific ST change, but nothing significant. And the lab work showed that his troponin was slightly elevated at 0.4. So the plan was to do a cardiac catheterization the same day. However, and patient received aspirin. Now, of course, it's a busy cath lab, and therefore the patient was added on as the last case of the evening. At about 9:41 p.m., the patient enters the cath lab. The procedure started about 13 minutes later. The patient was already hypertensive, probably anxious, and the blood pressure was 176/92. Radial access was obtained at 9:58 p.m., and GR4 diagnostic catheter was advanced to the RCA. Here is the first picture that shows that there is disease in the posterolateral branch. And here is another picture here. And then there is at 22:02, the GR4 catheter is removed and the blood pressure drops. The blood pressure drops to 91/41 from 176 at the beginning. So there is some concern what's going on. Anyway, we advanced the JL3.5 catheter to the left main. The patient, a minute later, the pressure dropped further, and we gave phenylephrine 100 micrograms IV for hypotension. We take a picture of the left system, and there is severe disease in ostial circumflex artery, and there is subtotal occlusion of the proximal/ostial LAD with the TIMI-1 flow. Here is another projection, shows diffuse disease in the LAD. Catheter disengaged from the left main at 10:07, and blood pressure continues to drop. It's 70/34, despite the phenylephrine dose that we gave, and he's getting tachycardic. Another dose of phenylephrine is given, and the blood pressure still doesn't change. The heart rate now starts dropping. It's at 53 now. He was given atropine right away. Blood pressure still very low, bradycardic. Is it just a vasovagal reaction? And then the patient was examined by the RN, and the rash was noted on the face, neck, and shoulders. The blood pressure still about the same. And now we gave epinephrine. And then we decided maybe this patient is getting sicker from the angiogram. So we decided to place a intra-aortic balloon pump. And we get right femoral access, and a balloon pump is in within 2 minutes. However, the patient remains hypotensive. Another epinephrine dose is given. A minute later, another epidose, and a minute later, another epidose. Blood pressure is not changing. Something is wrong. People respond to epinephrine, and he's not responding. So now we asked the nurse to check the IV. Is the IV working? And the IV is actually infiltrated. second problem. So a quick attempt is made to place a peripheral IV, but it was unsuccessful. So then we placed quickly a right femoral venous sheath, and venous access is obtained. Now we gave the epinephrine via the femoral venous access. Also, because of the rash, we give Benadryl right away, diphenhydramine, and give Solumedrol 120 milligram via the central venous access, famotidine 20 milligram, and blood pressure starts responding. So just a few minutes later, now the blood pressure has normalized, and then patient after that stabilized, admitted to the CCU with intra-aortic balloon pump. Contrast media allergy is added to the medical record. Cardiac surgery is consulted, and patient underwent 3-vessel CABG the following day. Discharged home on day 5 with the aspirin, clopidogrel, atorvastatin, beta blocker, good medical therapy. So in summary, this was a non-ST elevation MI. We had severe left main bifurcation disease extending into ostial LAD and ostial circumflex artery. And then the patient experienced an anaphylactic reaction to the contrast media with distributive shock requiring vasopressors and intra-aortic balloon pump. And then the IV was infiltrated, requiring emergent central venous access. Anaphylactic reaction is rare. It occurs in about 0.2% of cases, but most of the time the reaction is mild. That is minor reaction with urticaria, pruritus, and just erythema of the skin. A moderate reaction could involve laryngeal edema and bronchospasm, and severe reaction is circulatory shock, respiratory arrest, cardiac arrest. So this patient had a severe response because the patient went into cardiovascular shock. So the team which includes our nurses, our staff, basically saved the day. The nurse initially recognized this rash that the patient started developing after the injection of the RCA with the contrast. And then after the patient did not respond to the medicines, we realized that our IV, the peripheral IV, is infiltrated. And then, if we would not have obtained a central venous access, it could have been a big disaster. So essentially, a team-based approach is necessary in the cath lab. There is a reason you have a nurse in the lab, you have a technologist in the lab, you have somebody who's recording everything that's going on in the lab in addition to the cardiologist. So a team-based approach is critical to the success of cardiac cath lab in taking care of the patients and have good outcomes even when a patient experiences a complication. But as long as it is readily managed in a team-based fashion, the patients actually have very good outcomes. Thank you very much for your attention, and thanks for the opportunity.